I can inject like this. If I tighten this down, I can really inject like that, and I can put wires in and out this way. I can record pressures and the patient is not bleeding out, okay? So that's where the TUI Boris adapter goes and is connected. So what we're talking about right now is we're gonna do an angioplasty. This person I already know has a blockage in their LAD, very proximal. And so let's start choosing equipment here. So I've already done the angiogram. We're gonna pretend. I've done the angiogram. I know where my blockage is. So choose first of all my guiding catheter. What guiding catheter do you want to use?
7 French.
7 French? Well, I want to know the shape first. We're gonna go femoral. Oh, yeah, that's the first thing. We're gonna do femoral. Okay, to make it easier, we're gonna do femoral so I don't have to worry about the radio. JL4, okay, we're gonna use a JL4. And what is the normal size of a guiding catheter that's used if we're just planning to do an angioplasty or stent?
6 French.
6 French, that's right. We used to use 7s a lot, now mainly it is 6 French, okay? So I have to make sure I have a 6 French sheath in. Let's say I started out with a 5 French sheath, guess what I have to do before I continue on?
Change.
I have to change out the sheath. I have to put a wire in, take out the old sheath, put a new sheath in, take out the wire and dilator, and I warn you, that's a bloody mess. That is literally a bloody mess. Because I had a 5 French sheath in, so there's a 5 French hole there. So the first thing I need to do is take that 5 French sheath out over a wire. So I put a wire in. I have hiccups now. I'm falling apart. I put a wire in. I take the 5 French sheath out. Is there anything holding that hole closed? Is there any hemostatic valve there anymore? There's just a wire there, right? So you have a 5 French hole. Now you thought it bled a lot with a needle hole in it. When we're changing out the needle and you put it on the sheath, you think that's a lot of blood. This blood just gushes out. So somebody's holding pressure as the doctor is, so the scrubber is now holding pressure as the doctor is trying to load the 6 French sheath in and then taking the sheath and dilator out. The good news is once the 6 French sheath is in, the 6 French sheath is larger than the 5 French sheath, so the hole should now be secured. But if I start out with a 5 French, you really need a 6 French to do good angioplasty, and so I would have to change that sheath out, okay? And that is, has anyone seen one of those done yet? Sheath exchange? Was it a bloody mess?
Mm-hmm.
Yeah, it is. It's blood everywhere, right? They're just, it's not very attractive, but it only lasts a few seconds because it's just from when you take out the old sheath and you put the new sheath on very quickly, and then you take the dilator and wire out, and then you clean up the mess. But we're gonna pretend we started out with a 6 French sheath. Which is why most doctors for diagnostic procedures will start with a 6 French sheath. It's just a lot easier that way. Has anyone noticed, do you utilize for your diagnostic 6 French sheaths in the majority of the time?
Yes.
5 Frenches are nice because they're small. 6 Frenches are really needed for angioplasty though, and that's why most doctors just say, let's just start with 6. Even though 5 French would be more beneficial to our patients if we don't do an angioplasty, blood loss is not beneficial to the patient. So, we're gonna pretend we have a 6 French sheath in. So I'm gonna come up here and we're gonna go to inventory. And you told me you wanted me to do a 6 French JL4. So we're gonna get that up here, guide catheter, 6 French, JL4, select. Okay, and we're gonna start off with just a standard guide wire. We're just gonna get this, because we have to get this in place. So we're just gonna put up the 6 French guiding catheter up in place, as we usually do. So I'm going to take my guiding. We use the same diagnostic wire for intervention as we do angiogram. So you're going to use the J wire still. You don't open up a new diagnostic wire. So we just got done with the diagnostic. I used the diagnostic wire I used to put in the JL4 and JR4 through the femoral a moment ago to put in my guiding catheter. And what's the only difference between this guiding catheter and my diagnostic catheter? The lumen is larger. This is stiffer because the walls are thinner and the lumen is larger. Okay. Other than that, they're both 6 French. They both have the same outer diameter. And as we watch up on the X-ray, this guiding catheter will do the exact same thing. As my diagnostic catheters will do. My JL4, bada bing, bada boom. Pull it out. the LV, right? How did I know I was in the LV before I even stepped on the header? The pressures are an LV pressure, okay? So if I want to, I can do a little pullback here. I can do an LV gram. I don't need to. I can just do a little pullback, though. Boom. I'm at the aorta. And let's get that artery accessed. Let's get into that coronary. Can somebody puff for me? Can somebody set up my injector and puff for me since I can't do everything? I'm trying, I really am. I want 6 and 3. 6 and 3. You ready?
Mm-hmm.
Okay. Can you puff for me? That's good. Okay, take a deep breath in and hold it. Don't breathe, don't move. Inject, please. Okay, does everyone see the blockage?
Mm-hmm.
What if I told you that the blockage is deceiving? Can I see this for a second? What artery is this? Good. What artery is this? Circle. What artery is this? Oh, yeah. Okay. What artery is this starting? What artery is this?
Maybe diagonal.
Okay. Well, where would the LED normally go in this picture?
Oh, on the outer side.
Yeah, on the outer side, this direction, away from the spine. But it looks like the LED is cutting across in front of the spine. Is that what the LED usually does in a 40 LAO 20 cranial?
No.
So what would that mean about my LED? If we're correct in our assumption, what does that mean about my LED?
It's totally blocked.
It's blocked. And my diagonal isn't doing well itself. The LED would be totally blocked, and the diagonal looks like it has something in it as well. But we're making some assumptions here, right? We're assuming that this is what is happening. Regardless, I gotta fix that. Does that make sense? Even if that is the LED, regardless if that's the LED or not, I need to fix that. Does everyone agree with that? Okay. So I'm gonna put on my little bad Y adapter here. Oh, it's not gonna fit on this one. Okay, fine. I'm not using this Y adapter. Give me just a second. I'm gonna try to find a Y adapter real quick. This will make my life easier.
I talk to LED all the time, so that's bad.
Ah, here we go. That's the one I was looking for. Nope, that is not the one.
Yeah, and also like very low. Like at least because it's my first 2 weeks, so I'll go home with my food. A baby.
You put your left, you put your right, you down.
Okay.
Okay. Stress control.
Don't fear. Okay, myself out. Okay. So here is my Y adapter. And then the Y adapter goes here. And again, just like our other catheters, we want a wet to wet. So blood would be coming out of the catheter here. I would have saline coming out here. And we would connect. Okay, so before I go on any further though, does anyone want to know what I might want to do at this point before I go any further and ask for any other pieces of equipment? Do the what?
You need to do another test for the no, you said when you get the guide catheter in place and no, never mind.
We did the angiogram. We did the angiogram. So that's the next thing we would do. The first thing we do is any angiogram. But now that I have an angiogram, what do I need to know about that blockage? I already know the percentage. I wouldn't be putting the guiding catheter in unless I knew I was going to fix it. So I know it's greater than 70, but I do need to know something.
What type of catheter and balloon you would need?
Well, in order to decide that, though, I need two things. Size, that's right. I need the size of what?
The blockage.
The vessel. I need to know the size of my normal vessel, because that's what I want to get it to. And I also need to know the length of the blockage. Does that make sense?
Yep.
So now I already know I'm going to fix it, but I need to know the size and the length of the blockage. And the only blockage I can really see right now is this one right here. So who has this? Oh, Vanessa's going to jump in. Okay. I want you to calibrate my catheter first. So take a picture of this. So go to my series. We'll hand that off to somebody else. Pause it where you think it's a good picture. Is that good? Okay. Take a snapshot out of it. Okay. Go up to your picture.
Where is it? It's
Right
right
up there.
side.
Yep. So now it's the first thing you have to do.
Measure the French.
Catheter size. That's right. So what we go in French size? So go to French. Is it a 6 French catheter? Okay. So calibrate that catheter for me, please. Nope. Outside, out more. In. There. Okay. Is that going in the same direction as the catheter?
No.
The catheter's going in this direction, your line's going straight up and down. Redo that. If you need to zoom it in, you can if you want. Does that go from side to side? I think you're a little far out on that side. I can show you if we're going to zoom in. Oh, you already deleted it. So we're going to zoom in here. Not bad. There we go. So I want it to land right on that edge and right on that edge. Too far out. In, more. Out a little bit. In now. Right there, click. Okay? And go to the outer edge. But follow the angle of the catheter, straight up and down. My catheter's going at a slight angle, too much. A little bit more, right there. Is that pretty good?
Mm-hmm.
Okay, so now that we have it calibrated, you're gonna go to my vessel. And I wanna know the vessel right before that blockage right there. What would that be?
So here.
Okay. Okay. And follow the angle of the vessel. There you go. Out a little bit more. Out. There. Yep, right there. 2.5. Okay. Is that okay with everybody?
Mm-hmm.
Go distal. Let's see what it is down here. Oh, no, too far out. You're not touching the wall there. You want your pointer right against the wall. More in. There. Quick. And the other side. Out a little bit more. There. Between 2.5 and 2.2, somewhere around there. So it's greater than 2. And I want you now to tell me the length of that blockage. So start where it just starts to narrow. So go to the top where it just starts to narrow. Up a little bit higher. And you want to be in the center of the vessel this time. There, click. And go to where the blockage ends. In the center of the vessel, go down further. Is it still narrowed there? You see how it's still
Oh, okay.
right about there? Good. So about 4 millimeters in length. So between 2 and 2.5, and we're about 4 millimeters in length. Are we good with that? Does everyone remember that? Because I'm not going to remember that. Can somebody remember that for me?
What's the name?
4.
4.
So I told you I would remember 4, okay? 4. Great. Now we can go to my inventory. Okay. Get device. The first thing we're going to start off with is my 014 wire. I want to use so extra support is really stiff, light support is
Light support.
light support, yeah, it's kind of like a floppy. We're going to go with the workhorse. Workhorse is the intermediate that we like to use. Intermediate.
Straight.
Go 190, that's good, and give me a 30 degree, that's okay. Hit select. Okay, we're not going to go any further because before I pull a balloon on, as soon as I pull a balloon on, guess what happens to the patient's cost?
Increases.
It increases. So most doctors will wait to get the balloon on until after they pass the lesion with the wire. Why would they do it in that order? Why would they not take a balloon on until they make sure that their wire is gonna go past the lesion?
So they can't pass the lesion, there's no point in ballooning?
That's right. If you have a balloon on, they're gonna pay for it, whether you use it or not. So if you can't get past the lesion, which does happen, you'll see it in lab, you're just gonna work. Has anyone seen that yet, where they just kind of just say, done, we've tried, we can't get down it?
Yep.
That does happen. And if you already have the balloon on, the patient's paying for that balloon. So oftentimes we try to get past the wire first before we choose the balloon, or before we take the balloon on. So I chose a 190. Is that a short or a long wire? That's a short wire. 190 is a short wire. What does that tell you about what balloon catheter type I'm going to be utilizing? Monorail. If I was going to use an over-the-wire balloon catheter, what would my length have to be?
300.
300. So by the fact that I chose a 190, you automatically know that the catheter type, the balloon catheter type I'm going to use, not the balloon type, but the balloon catheter type I'm going to use, is a monorail, also known as a, what's the other name? Rapid exchange, also known as? RX. You were close. You were darn close. RX. Okay. So I have my TUI Borst on here. And the benefit of the TUI Borst is I can leave it hooked up to my contrast, my manifold. And at the same time, I can put this in. However, I have a 30-degree angle on this. So I'm going to use my introducer tool. What does this look like? This looks like an arteriotomy needle. How do you know it's not an arteriotomy needle? Because if I was holding it like this and it was an arteriotomy needle, what would be happening right now?
You'd be bleeding.
It'd be going through my finger, okay? The introducer is completely blunt. Can you agree that that's completely blunt?
Mm-hmm.
Blunt?
Yes.
You're not going to test that, okay? Blunt?
Yes.
Okay, she's just trusting me on that. Kind of tentative. Is he going to stab me? Completely blunt. Do not get this mixed up with your arteriotomy needle. That's a bad day. Do you agree that this is blunt?
Yes.
Okay, blunt. 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 Okay. Ouch. I just switched it at the last second. I stabbed her. So you're all welcome. Okay. So I'm going to put this into my Y adapter first. And that allows, because if you look at this Y adapter, there, you can see in this Y adapter the little valve right there. It's a little rubber valve. And if I try to put the wire in through that rubber valve with my little angle that I put on it, which is 30 degrees, that'll munch up that angle. So by putting this in here first, I can insert this pretty easily. If I was paying attention, there we go. And I'm just going to slide this down now. And can somebody help me over? Well, Harrison, can you help me over here? You're running my computer.
Yeah.
Okay. So you're going to hold that container. You don't take it out of the container. You let me pull it out. You let the doctor pull it out of the container. You puff for me. Did it go down the right artery?
No, so
Oh, okay, I'm gonna try again. Puff for me. Is it going down the right artery?
hold on.
Why is it not going down the right artery? I'm turning it.
You need.
Is there something I can do to make it a little bit easier for me to guide this into place?
Yes.
And what is that device called? The torquing device. Now, since the wire is in, to get the torquing device on, I'm going to take the introducer off, because the introducer has to come off. Oops. Take the introducer off. I'm going to insert my torquing device and go to 6 inches. Zoom into, I'll do it here. Let's zoom into 6 inch. Actually, that's good, 5 inches. Good. Okay, so I'm gonna show you where my catheter is. Now you're gonna be able to see me, you'll be able to see I can now turn my wire much easier with my torquing device on. You can spin it a lot easier. Go down, puff for me, can't remember where I'm at. Is this going very easily for me? No. Puff. Now why do you think I'm having trouble getting it in there?
The angle is
Well, the
right.
angle bend so.
Oh, I said that and then what happens?
Got it in
Sometimes you
there?
have to talk to your equipment to get it to work. So now where's my wire? Puff? Oh.
In the LED.
Oh, wait a minute, it's going down a small artery here. Boy, we didn't see it go down there, did we? Oops. We do have a problem right now. Does anyone know what rhythm I'm in?
Oh,
VFib?
This is VTAC VFib. Yeah, fine VFib. We haven't gotten to there yet, but that's bad. Can you go to medication for me for a second? I don't think that's what I want. No, go to Proctor. No. Go to vitals. It's not vitals. I lost me. Okay, so does everyone agree we're in VTAC?
Yeah.
Okay, go to procedure. Go to defibrillate and hit shock. Shock.
It's not.
Oh, there we go. Did we get them out?
Yeah.
Does that EKG look better now?
Yep.
By the way, what rhythm is he in right now? If you look at
sinus.
Normal
normal
sinus.
sinus, my heart rate is
78.
78. Do I see a P wave?
Yes.
Do I see a QRS?
Yes.
Yep.
Do I see a T wave?
Yes.
Yes.
Are they in the proper order?
Yes.
Is the P to R interval look, we're not measuring right now, we're just eyeballing it, look okay? Does it look, the P to R interval, the length between the two look okay?
Yes.
Until we only know one rhythm.
Yeah, that's right. But I'm still making sure it is. Remember, it either is or it isn't. Is the P to R ratio 1 to 1?
Yes.
Yes. Okay. Is the QRS fairly skinny?
Yes.
Yes.
Yes. Does it? What would this be then?
Normal sinus
Normal
rhythm.
sinus rhythm. We have a little bit of ST problems here, but we're not there yet. So, but we have normal sinus rhythm. So now we're back. Okay. Well, what happens is something very strange. Well, we just saw something called a reperfusion arrhythmia, and we don't really understand why they happen. And oddly enough, they happen more commonly when we do the right coronary artery, not so much when we do the left. But what we think happens is for so long, the muscle being fed by this artery has been without oxygen. So when we all of a sudden restore oxygen to that muscle tissue, guess what it does?
It's in like shock.
It gets excited and it freaks out, and it goes into VTAC or VFib, which is a deadly rhythm. That's that little wiggly line that you saw. It's called a reperfusion arrhythmia. It's caused by us getting blood or reperfusing, getting blood back down to that tissue that was ischemic. It's not uncommon, but it's weird. Because you should think, well, if I got blood down there now, what should the muscle should be happy, right? Matter of fact, when the ischemia is there, you would expect the patient to have an arrhythmia, right? You would expect the patient to have an abnormal rhythm. When the oxygen isn't there. But for this situation, when we restore the oxygen, the tissues are like, ah! They don't know what to do anymore. And they freak out, and you go into arrhythmia, and you have to step in and kind of, excuse me, my poor children, kind of remind them a little bit who's boss. Kind of, we'll smack on the butt a little, just real quick to get their attention, and boom, the artery goes back to normal. Okay, just a little, hey, to knock it off, and the ventricle's like, oh, okay, I'm back to normal. The toddlers were running wild. Okay,
So when that happened, like, is it pulseless VTAC?
they will not have a pulse. That was a very fast VTAC. Anything
just
above
didn't-
170 will not have a pulse.
Okay.
So, yeah. So we shocked him out, and he's now better. But now, watch what has happened. I'm going to advance my wire a little bit down there, if I can. I'm going to see if I can. Okay, let's see what happens here. Vanessa, we're going to inject. Ready?
Yep.
Take a deep breath in and hold. Don't breathe. Don't move. Hit me. What do we see that we didn't see before?
LED.
You see,
Wire.
and you see that there's a vessel, a part of a vessel there that we didn't see before. We didn't see the second little blip down there in our first picture. Go to our first picture, please. Go to procedure. Yep. No, I'm sorry. Series. I'm sorry. Yeah, series. Go to the image on the left. Yep, that one right there. Okay. So if you look right here, it just ends right there. Do you see that? Now, when I compare it to where we're at, I see that there's a vessel beyond that point. So were we right? Is this the LAD or is this the diagonal?
Diagonal.
It's the diagonal. That makes this the LAD. That changes how we're going to approach this, isn't it? Okay. We got to fix that LAD quick. So, my measurer. Measure. Take a picture, take a snapshot of, pull this one up. Pause it. Take a snapshot of that. Calibrate that catheter. Tell my toe that hurt.
You will fix the visible part of the vessel first, right?
Yep, always go to what you can see. You always go what you can see first. So there. Well, we have to calibrate first. Calibrate. So hit the undo arrow. Undo arrow. Calibrate first. There you go. Yep, 2 millimeters. That's right. Click. And click. Oh, in. Too far out. You missed it. Try again. Click. Click. And go pull in, pull in, pull in, pull in. There. 2. Does everyone agree? Is that okay to everyone? Don't just trust my eyes. I'm not wearing my glasses. Does that look okay?
Mm-hmm.
Everyone agree with that? Okay. So now I want you to measure this healthy vessel up there. Down a little bit. Down, down. Okay, yep. Pull it in, pull it in. You got an itchy trigger finger there. First you have to go to vessel. Pull in a little bit. Out. Click. Find the opposite wall. Up. Up, up, up. Down. I think you're too far in. Click. Do you think that's really 7.58? It's not because you're in French. We're only doing millimeters. So, how many millimeters? 2.5. Does that sound better? It's about what we had last time, right? Is that correct? Was it 2.5?
Yeah.
Okay, good. Thank you.
Yeah.
Okay, so now we want to know the length of that lesion. So go from there to there. From up here, where the blockage starts. Yep, click. And at least all the way down here to the middle of that little bubble. Keep going down. Down, 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 follow the wire, down, 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 down to the second bubble, down, 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 down.
Second bubble.
And then, yep, in the middle of that. Click, just click in the middle. So now it's about 7 millimeters in length. Okay. So now I have my wire past it. I know I'm going to use a monorail. Do you think I'm going to use a compliant, non-compliant, or a semi-compliant balloon? Semi-compliant balloon. And what is my diameter do I want my diameter to be around?
2.5.
Around 2.5. At least with the balloon. If we're going to do a stent, we can decide that later, but at least a 2.5 with the balloon. And what should my length be at least?
7.5?
Probably 9.
7, 8. Well, let's take a look what we have. Okay, so now I'm going to go tell my circulator, give me a balloon that is 2.5, about 8. So now go into my inventory. You're going into the back room now.
Because the balloon is longer than the lesion, right?
It should be a little bit longer than the lesion. Yep. So let's go to my balloons. Those are dilation catheters. Not a high. We don't want a high force balloon. Yep. There we go. We want a 2.5. Oh, look at that. We have a 2.58. Are we happy with the 2.58? We have the next one is a 2.512.
258.
2.58. Is everyone okay with that? Should I at least start with that?
Yes.
Okay, let's start with that. Give me a 2.58. And what is nominal? Click on that.
What is it?
Click on this again.
Oh,
And it'll tell you the nominal pressure is what?
6.
6 atmospheres. And the rate of burst pressure is
14.
14 atmospheres. We good with that? Can anyone remember that for me? What is my nominal?
6.
Seamus was like, I got this. Nominal is 6. My rate of burst?
14.
14. And anything above that is max. I don't want to go anywhere near that. But I definitely needed my nominal and my rate of burst. Okay. In reality, this is the balloon I'm going to be using in reality. And you can see it has this chart on the box. And if we open this up, we also have this chart on the packaging, which is not sterile. This packaging is not sterile. And oftentimes, even when you open it up, there's a chart that is sterile on the packaging, okay? And it tells you what the nominal pressure is and what the rate of burst pressure is, okay? And what the size of it will be at those pressures. Okay, so now you grab this to me. The scrubber gets this on the table. The doctor's not paying any attention to this. He's walking to the patient. Stacy, come on up here for a second. Get your hands in your pocket. I said you had your hands in your pocket. Here we go. Oops. Stay. Hold that for me. Prep that for me. Like we did last week. We don't flush this in.
Flush.
The distal end, it's in there, but you don't do that yet because what do you have to do first?
Connect.
Yep, connect that. And where does that connect? Okay, connect it to that. There's only one place for that to connect. With a monorail balloon, I don't have that Y at the end, so whatever is out. So now, put that down. What am I going to do?
Burp it.
Burp it. Okay. Hold it like this. Use this thumb to lock and unlock. This is locked. This is unlocked. Go ahead and burp that for me. Unlock. Pull back. All the way. Pull back all the way. Lock it.
Sorry.
We're gonna wait and watch these air bubbles come back. And they already came back. Release and go neutral slowly. There you go. Burp it again. Watch the air bubbles in the line here. Pull back. Nope. You have to unlock it. Pull back. Lock. Okay. See the air bubbles moved up suddenly.
Not moving.
Yep. Once it stops moving, we can go to neutral. And we're gonna do it one more time. Pull back. Negative. Lock. Okay. So if the air bubbles move up, we're gonna give it a second. And go neutral. Okay, so it's now burped. Okay, put that down. So now, something I'm going to show you that, and we'll practice this. This is more for demonstration. We'll practice this next week. To get this over to the table, you don't. Some people bring this whole thing there, but then you're trying to unwrap it at the table, and you want as much as you want on the back table here. So if we just take it in a nice big loop like that. They will all come with a little wire inside of them and this little plastic covering that goes over the balloon, okay? These are all, can you hold this in for me for a second? I accidentally yanked it out too fast and it got caught, but these should come out. They'll be on the balloon like this, okay? That's to protect the balloon, that's to protect the catheter. You don't want to throw these away. And the reason you don't want to throw these away is if the doctor wants to go back in with the balloon, what happens with, how many of you have ever blown up a latex balloon and then deflated it? Did it ever go back to its original size? Does it ever go back to its original shape? It's permanently deformed, right? Well, the same thing happens with the coronary balloon. When you inflate the coronary balloon, when we deflate it, it doesn't go back to its original size or shape. So oftentimes, if the doctor wants to reuse this balloon, that balloon being deformed can make it catch on the plaque. So now that the balloon isn't nice and tight, it can catch on the plaque and it won't advance forward. And you're like, I just had that in there. How is that possible? Well, we can rewrap the balloon. Once the balloon comes out, we put this back in it, and in a twisting motion, and you should always do it clockwise, in a twisting motion, as that slides over that balloon, guess what it's doing to that balloon? It's wrapping it back into that shape. It's called the rewrapping. When you take it off, the balloon, I shouldn't take it off like that because I just contaminated everything, but when you take this off, the balloon is now nice and tightly wrapped. So don't throw this away. And that's why you want to keep it back here so that it doesn't get caught up with anything over there. Once it is nice and flushed out, we'll bring it over here. So everyone now come look over here so you can see what we're going to do. While the scrubber is getting the balloon ready, The doctor is going to tighten this TUI Borst down. So we're tightening down that valve. Now, the reason I do that, Shannon, can you come up here and do me a favor? Tug on that. Don't tug really hard, but tug on that wire a little bit. Not just the wire. Just hold the wire. Tug on there a little bit, yeah. Is that gonna go anywhere?
No.
That's pretty tight, right?
No.
So if you tug on this, remember, what do I not want to have happen to that wire now that it's in place?
Come back out.
I don't want it to come back out. So as I'm sliding things on and off of this wire, if I can tighten this down, and it's not gonna move backwards or forwards, I can take things, go ahead and take that off. I can take that off, and she doesn't have to worry about moving the wire back. That's the beauty of the TUI Borst. That's the beauty of the TUI Borst. Okay? The TUI Borst allows us to keep the wire in place and hold it in place. Okay, so now what do I have to do?
Inflate.
No, the balloon's not in the body yet.
You need to test the contrast.
Test the contrast.
I thought you, once you get the wire in, you have to do another test.
I already did. Because remember, we took a picture and we saw that extra.
Insert the catheter balloon?
Yeah, we gotta get the balloon back on. Jen, step on up for me. We're gonna see how big your eyes are today. Everyone's gonna play a game here. So I want you to try to put this distal balloon onto that wire. Oh my gosh, how long did that take you? Like 30 seconds? Okay, so keep advancing it forward. Okay, and watch where let's watch the wire come out. So let's see where the wire comes out. There it is. So we're gonna straighten that out. And the cool thing we can do with this, I'm gonna show you a little trick. If I take my indiflator and put it down here, watch what happens to the catheter automatically. So my indiflator is here. Is my catheter popping off the table? So go ahead and let go of it.
No.
Is the catheter popping off the table? You're gonna stay here for a second. Is it moving a lot? No. This catheter, this balloon indiflator is acting like an anchor. It's holding my catheter down so that the scrubber or the doctor doesn't have to hold my proximal end. Okay? This is holding it down on the table, and so all you had to do was hold this tip and try to get it on. No, you're not trying to hold these things. Use your indiflator as an anchor. When you bring this over, unwrap the balloon, use the indiflator as an anchor, and that way this is all on the table, not moving, not flopping around, and all you have to do is hold this. So now what I want you to do is I want you to take your fingers and you're gonna pinch it and hold it to the table as tight as you can. Don't let it move. Pinch it, hold it, good, and I'm gonna take care of everything else. Your job is to hold that wire in place. Look up there, you see where the wire is? See where the distal wire is? Can you put your arrow on the distal wires for me? Who's my computer controller? Distal, that's proximal. Distal, okay. Don't want it to move. Now if it moves, what's gonna happen?
Come out.
The wire's coming out or going forward. If it's going forward, what could that wire do to the artery?
Puncture.
Could perforate or puncture it. That would be bad. If it comes out,
We do it.
what could happen?
Spasm on the artery.
Spasm of the artery, and I could lose access, and this person's gonna have a heart attack, and I can't stop it anymore. Also, what's gonna happen if it moves, you're gonna get yelled at. I won't yell at you, but a doctor might lose his cool because the risk is we perforate or we pull back, and we can't have either one. So the doctor will say, "What are you doing?" Okay, they will be sharp because they need you to pay attention now to stop what you're doing, but you're gonna do this just fine. As long as you hold it there with the monorail, as long as you hold it and you pinch your finger and you hold it to the table, that wire should not move. Does that make sense? Don't hold it with your finger like this. I see people do it like this with one finger pushing down. Don't hold it like that because it's against the drape and this could slide underneath your finger. The only way you know for sure is exactly as you're holding it right now. You have it pinched between your two fingers tightly and both of your fingers are on that table. Don't put two fingers on it and pin it like this because a wire could slip underneath your fingers. I see too many people do it and I've seen too many mistakes. Hold it. Okay, you're doing great. And I'm gonna slide this forward. Now I'm gonna continue to slide this forward, and in a second the doctor I'm gonna show you something the doctor can do. As it slides forward now, if you look, if I make the OK sign with my finger here, these two fingers of the doctor's can now pinch the wire here. And this hand can now feed the catheter in. Guess what you don't have to do anymore? You don't have to hold the wire anymore. The good thing about the monorail wire is your responsibility for the wire is only for a short period of time. Once the catheter gets far enough into the Y adapter, the doctor can hold wire themselves like this. And when he or she says, I got wire, what can you do? You can let go. And you can pick up your end deflator. So go ahead and do that. Go ahead and pick up the end deflator. Yeah, go ahead. And you're going to pick up this one. Can't use this one because this is a simulator and it's stupid. So you're just going to hold it like that. And now the doctor has the wire. You can see I have it pinched. I'm going to slide that catheter. I'm going to slide that catheter. Watching. You notice my eyes are where? On the monitor. Are my eyes ever looking at my hands? Should your eyes be looking at your hands? No, you always want to look at the monitor. Because I want to see the vital signs. I want to see if they go into VTAC again. I want to see if that wire comes back. And I want to see where this. Pull the wire back a little bit myself. No, come on. Can you puff for me, please? I think my catheter came back. It did. Puff. Do you see how my catheter backed out?
Mm-hmm.
That's what I mean by backing out. Once you go past, the catheter will want to back out. So I have to be very careful to keep that catheter in place, and that's the doctor's business. You see the balloon? Watch again. You see the balloon?
Mm-hmm.
You see two dots right outside the catheter. Boom. You see those two dots there?
Yeah.
I'm gonna step on X-ray so you see them clearly.
Okay.
You see those two dots? Those two dots are the metal dots that show me what? The effective balloon size. So I want the lesion between those two dots. Can you puff for me, please? Okay, so I'm going to back this out because my first lesion is back here. Is that balloon big enough? Go ahead and inject. No,
Did it
it's not.
inflate?
Yeah. No, it's not inflated. It's just the length of it. Is it as long as we want it. So go ahead and pull up our series. Here's our last picture. We want it to go from here to here. And you notice it's not big enough, is it?
Mm-mm.
And the reason for that is we're looking at it a two-dimensional image. What we can't see on this image is the artery actually comes out a ways this way before it drops down. We just measure it as if it was straight down like this. We didn't take into account that it comes out this way and then down. So yeah, we would need a different view to get the accurate, which is why we always, before we do an angioplasty, we do a full angiogram so we look at all the different views. I just chose one here. You just look at all the different views and see it. But we're going to work with this as we have it in. Okay, puff for me. Okay, so we're going to start there. What's nominal?
14. No.
What's nominal? You're failing me, Shema. Your time here. You're failing me.
It's 6.
6. Okay, so now what she's going to do is she's going to slowly turn clockwise. You're going to turn this clockwise until that reaches all the way up to the 6. And as she's doing that, let's watch under X-ray, watch what happens. Pull it kind of straight up and down like that. There you go. Keep turning it until it reaches 6. No, it takes a bit. No, it'll take a bit. There it goes. Good grief, there's one in here. Make sure for the right thing. inflator. Let's use this one, it might be a bad inflator. Hopefully it's a bad inflator. Okay. Can you fill this with more water here? Can you fill this with more water?
Need a towel for that, for water?
How much water do you want?
10 seconds.
I think I got a little more than that.
That's okay. 'Cause we're just playing fishing in the ocean right now. Okay, let's try this again. Try to make sure to get this to its place. I just let it. This would not happen in real life. Grab me one of those insects, please. I'm trying to fix this on the side. Give me one of them. You can only get points so if you can tell me what type of hemostat is this.
It's a mosquito.
Nope.
It's a curve or something.
Okay.
Kelly?
Not a Kelly. Why is it not a Kelly?
Oh, it doesn't go all the way.
It doesn't go all the way, so it's a cry. It goes all the way down, so it's a crowd.
Oh, what?
Crowd. Crowd.
A cryo.
It's a fly.
I don't have time to look those papers. There's a test today, so.
Kelly's the good girl, she doesn't go all the way. Brian goes all the way.
I would never forget
so
this
sorry
one.
about that.
Right?
I would never.
You date Kelly, but you marry Cryo. That's the way it
It's
works.
C-R-I-E.
C-R-I-L-E. C-R-I-L-E. So let's see if this works better.
Oh, and then, okay, okay.
There we go. Okay, it was bad tubing. So if I go up now, go up into 6. Keep inflating to 6. And as she does that, we will see what's happening to the balloon.
Completing.
There it is. So go up until it says 6. 6. Very good. And you can see how it's still a little pinched in the center there. So let's go up to 8.
8.
That looks better. Go up to 9. What's my rate of burst?
14.
14. 9. 9. Okay. I took a picture of that. We always want to take a picture of the balloon inflated. That's proof later on. If somebody says, did you inflate it? We can show proof under X-ray that we did. Go down. Deflate.
Go
So you're going to go
Negative.
counterclockwise quickly. 3 turns. 1, 2, 3, and then go negative and pull back. So open this up, pull back, and then lock it again. There you go. And as she does that, so you always want to do it 3 turns counterclockwise, and what that does is that allows the balloon to slowly release from the vessel wall. If you deflate too quickly, you can pull the vessel wall along with it because the vessel wall is tacky, it's sticky. And if you pull the vessel wall with it, what are you going to cause? A dissection. So you slowly go counterclockwise a few turns to slowly get that balloon off of that wall, and then you deflate quickly. And so let's see what we did. Are you ready to inject for me? Let me make sure my catheter is in the right place. My catheter back way out. My catheter is an entirely different zip code. Okay, there we go. Ready? Take a deep breath in and hold it. Don't breathe, don't move. Inject. Whoa! Does that look different?
Mm-hmm.
You're actually
But we still have that little pinch there we haven't taken care of yet, have we? Okay, do you see that second pinch that we haven't quite made it to?
Mm-hmm.
So guess what I'm gonna do with this little balloon?
Push it in.
That's right, I'm gonna go and advance it. I'm gonna get a 2-for-1 here. I'm gonna go in and advance it. Can you puff for me? Okay, I'm gonna step on X-ray. Is it, I want that blockage right between those two, so inject. Is that blockage between those two dots?
Mhm.
Can we back up a little bit more? Okay, I can do that like that.
Mm-hmm.
I'm okay with that. Okay, what is nominal?
6.
So go up to 6. So go release it. Yep, go neutral, lock it. And go up to, you see 6 up here on this, on that. No, just go neutral. Yep. And then just keep, it'll take a bit. You'll keep turning until you start seeing it go up. There you go. Starting to go up. And as we step on this, we will see that the balloon is inflating. Okay, is that fully deployed?
Mm-hmm.
You see a little narrowing in the center?
Mm-hmm.
It has a strange turn to it. You'll hear it called dog boning. And it's called a dog bone because if you think of a dog's bone, what happens to either end?
That's bulging.
It has the bulging out and the center's nice and narrow. If you look here, either end is bulged out a little bit more and it's a little narrowed in the center. That's called dog boning. Go ahead and inflate a little bit more. Go to 10 for me. There you go. You see how it's a little bit smoother now all across?
Mm-hmm.
30 seconds. Come down 3 times counterclockwise. Not yet. 3 times counterclockwise. 1, 2, 3. Unlock, pull negative. All the way back negative. And lock it. Okay. And now we're going to pull this balloon back a little bit so we can get a good picture. I want the wire to stay in place. I pull the balloon back. And let's see if we heal this patient. You ready for an injection? Take a deep breath in and hold it. Don't breathe, don't move. Inject. Does that look a lot better than it did?
Mm-hmm.
Mhm.
Pretty cool. We just fixed an artery. Okay. But am I done yet?
Nope.
Why not?
Daniel is still pending.
LEDs.
The diagonal, the LED's fixed.
Yeah.
My diagonal's still in here. Okay. So I'm gonna come back with my balloon here. Keep pulling that back, pulling that back. Okay, now I'm gonna have you watch my hands this time. I'm gonna watch the screen. I want you to tell me when the balloon is out of the tweet boards, okay? Yep. Look over my hands and just watch the balloon come out. Tell me when it's out. Is it all the way out of the tweet boards?
No.
There it is. I'm gonna tighten that down. Oops, don't pull that down. Now we can slide that off. Just put that on my back table for now. We'll get it in a second. So are you glad now that we took a picture before we did it?
Mm-hmm.
Okay, next person up. Agar, come on up and help me. Oh, you don't feel well? Okay, then you should go. I don't want you to pass out on me. Okay, then you can head out. You saw most of it. Kim, you've already got the picture, haven't you?
Yeah, I helped.
Oh, and you two have it, but you guys are filming. So, Kim, come on up over here for me. I want you to load the, Be Well. Load this for me, please.
Feel better.
Jen has those healthy, good eyes. There you go. And now what I'm gonna have to try to do is I'm gonna back this out. What am I gonna have to try to get this wire to do? Go down the diagonal. Puff for me, please. So this part, the wire will not want to do. It will not want to do that. Go puff for me, please. I speak badly about the wire and then it does what I want it to do. And you want the wire to go down as far as you can without getting into too small of a branch. Because the farther down it is, what is it less likely to do?
Pull back.
Pull back. Little puff. Alright, that's good. Bring me back that balloon again, please.
So you want to use same balloon?
Yep, you can use the balloon, same balloon over and over again. And you won't have to rewrap this one because it didn't really, but ideally, if you had time and we were gonna use the same balloon, you would rewrap it. Yep, go ahead, pull it out.
Can you put the wire straight to diagonal instead of pull the balloon out?
Say that again?
Keep the balloon in there.
It's harder to because the balloon will want it to go straight,
Uh-huh.
and so I needed this wire to curve
We need more
around.
space, so that's
Yep.
why I pulled it out. Okay.
Let's hook this up to this, so you can use this as your anchor. So let's anchor this down. There you go. So you won't have to worry about that tip. Keep it fancy. Right. Okay. So grab it. Okay. Hold on tight to it. Remember, pinch it straight down. Good. Okay. Hold it to that table. And you notice my catheter keeps backing out. And that's that rule. When the wire goes in, the catheter will want to retreat. And it moves along. Love it when physics can be demonstrated. Okay, here we go. Okay. I have the wire, you can let go. Grab the anchor, but I can really grab this. So we can go straight down. Again, I'm gonna advance this all the way down to my vessel. Okay, you see the balloon? Is everyone see the tube marks? Okay, where's my injector? Oh, you ready? Inject. Yeah, I know I have a lot of X-ray. You think that's okay right there?
Mm-hmm.
Is everyone good with that?
Mm-hmm.
Yes.
Does the marker on either side of that blockage?
Mm-hmm.
And the doctor often will ask, do you think I'm for an extra set of eyes? Does this look good? Am I in the right place? You might hear the doctor talk to the scrubber saying, does that look good? They just want confirmation. And I'm asking for the same thing because I'm getting old. So if you say, hey, can you come back, Jen had a good point. She said, I think you should come back a little bit further. So I pulled it back a little bit further and it worked well. Okay, let's take one more picture. Take a deep breath in and hold it. Inject. I'm going to pull back a little bit. There we go. What is my nominal?
6.
6. Okay, go up and inflate to 6. So actually, you're going to go neutral. No, go ahead. Go neutral. Lock. Lock this. No, don't go at neutral. So let it go neutral. Let it go. Lock. Okay, now count clockwise. Turn it clockwise until this goes to 6. As she goes clockwise, we will see the balloon start to inflate. Is that 6?
6.
Okay, is that inflated enough?
No.
No, it needs to be bigger. Go to 8.
Okay.
Is that big enough yet?
No.
No, still a little narrow in the center. Go to 9 or go to 10.
Are we concerned about the distal and the?
If the middle, we have to, the whole reason we're doing the angioplasty is to open up the middle. So if the middle isn't opened up yet, it doesn't matter what's happening distal or proximal. Go ahead and go to 10.
What is the total, this can be extended?
14.
14.
14. Yeah. The rate of burst is 14. Down, go down, deflate. Go 3 times counterclockwise. 1, 2, 3, unlock. Pull back, all the way. Lock. And the balloon will deflate. I'm going to pull the balloon back here. And we're going to see You ready? Take a deep breath in and hold it. Don't breathe, don't move. Inject.
Nice.
Now, how does that look?
Better.
Okay, let's go to 8 inches. Zoom out for me a little bit. Go to 8 inches. We're at 3 right now. Other direction. Take one last picture here. Let's get this all together. Take a deep breath in and hold it. Don't breathe, don't move. Inject. Now tell me, pull it up over here under series. Pull up my very first picture, so scroll down to my very first picture. Go ahead and scroll down. Play all the way down. Yeah, click
It's all the way down.
further. Is that all the way down? No, you should be able to go down further. There you go. Click on that one. So that's what it looked like before. Scroll up as we're still playing. So everyone look at what it looks like before. We did not change views. Click on it. Does it look different?
Mm-hmm,
Does it look better?
mm-hmm.
We just saved a life. We just open up that vessel and repair that vessel. Okay. So some key takeaways here is it requires both the scrubber and the doctor to work together. When to hold, when to pin, how to hold. But in reality, was it very hard to inflate the balloon? No, very easy. Was it very hard to hold the wire and get the thing loaded on the wire?
No.
You had a lot easier job than I would have done it. Was that?
Just nervous.
Just nervous, that's right, but it's, did a very good job with that. Controlling the wire and controlling the catheter is the biggest thing. The doctor has to worry about the catheter backing out and not having good stability. He knows I had to keep positioning the catheter in there. And that's one place where the guide liner helps. The guide liner can go deeper into the artery so I don't back out as much. So if this device had a guide liner in it, we could utilize it. Other than that, it is working effectively. Questions on angioplasty?
So actually, they put guideline in there.
We could have,
You could have, okay.
yeah, we did not. Yes.
Is the destination sheet box also just like a
Destination sheet is just kind of the same thing. Yeah. And it holds, that's more for peripheral, but yeah, it kind of does the same thing. It holds the catheters in place. Because this device doesn't like the floppy end going first. It's the simulation thing. So that's the reason why.
So in here, like the catheter pop out, right?
The what?
The catheter that pop out, like.
Yeah, in real life, the catheter will back out, just like
Yeah,
what you do.
you do
Keep
it,
repositioning it, yeah. And if you're not careful, if the catheter backs out too much, it's gonna take, it's gonna take all the wire and the balloon with it. And that is a nightmare scenario.
So if you put the balloon right on that, like you leave a small part of the lesion out of that area of the balloon, what could happen?
You're gonna have an unequal distribution and you won't get a full deployment of